Good evening. Welcome to the GHAPP MASLD Community Network, sponsored by Madrigal. I'd like to thank GHAPP and Madrigal for giving me the opportunity to speak to you all tonight about, if I can advance my own slide, about MetALD. Sorry, there we go. My name is HoChong Gilles. I am a nurse practitioner at the Richmond VA Medical Center. And I've had 25 years working in, having the privilege of working in hepatology. If you, just to remind everyone to use this QR code to record your attendance for this meeting, that would be wonderful. And I'll give you a minute to take a picture of that. Okay. We're going to first start with the case. This is Ashley, who is a Caucasian female that's 52 with a BMI of 29, a little bit more than 29, that was referred for an evaluation due to an incidental sonogram that showed mild hepatomegaly and increased hepatic echogenicity consistent with hepatic steatosis. She has no complaints otherwise. So her medical history includes a polycystic ovarian syndrome, hypertension, and hyperlipidemia. So right away, you know that she has risk factors for metabolic dysfunction-associated steatotic liver disease. On her social history, she averages about 2 glasses of wine per day. And on physical exam, you know that she's non-tender, smooth liver edge, no other stigmata for cirrhosis or hypertension. Her meds include amlodipine for hypertension, atorvastatin for her hyperlipidemia, and milk thistle and multivitamins for health maintenance. So when you get additional information, she is slightly hypertensive. Otherwise, her BMI is 29.4. Her ALT is 46 and her AST is 55. Alk-Phos 140, her total bilirubin is 1.2. A good platelet count of 210,000. A hemoglobin A1C of 5.9%. So, evidence of some insulin resistance, and her triglycerides are slightly elevated, 185. But one of the things I want to point out to you is, the pattern of her ALT and AST. And as you can see, her AST is higher than her ALT, but her platelet count is 210. So, but I want you to think about, the pattern is, typically in cirrhosis, you can see the inversion of the AST being greater than the ALT, but you can also have that ratio of an alcohol related liver disease. So we do a fibrosis assessment. We do a fibrosis assessment using the FibroScan or VCTE, which is vibration controlled transient elastography. And you can see that she has pretty significant steatosis, pretty severe, with the CAP score of 310. And then her KPA, which is a reflection of hepatic stiffness, which is a biomarker for hepatic fibrosis, is 11.4. So with that range, you're thinking that she is in the F3 range. Okay, so she probably has bridging fibrosis. So, pretty concerning given the absence of her symptoms. So in 2023, there is a multi-society consensus that renamed the umbrella of steatotic liver disease. And you have metabolic dysfunction-associated steatotic liver disease of MASLD. It was really the umbrella for those that have metabolic syndrome and metabolic features. And then you have the severe form of MASLD under that umbrella known as MASH, which is metabolic dysfunction-associated steatohepatitis. That's characterized by hepatic ballooning. You have injury, and but you can have MASH without fibrosis. But we want to really focus on those that are at risk, that we will discuss further, for those that have significant fibrosis, which is known as F2 to F3. and then F4 being cirrhosis. But I like this because there are many reasons why you can have steatotic liver disease. You can have, drug-induced liver injury, and there are certain drugs that can cause steatotic liver disease. You have monogenic diseases like, Wilson's, and other miscellaneous like hepatitis C, because genotype 3 a long time ago was associated with increased hepatic steatosis. And then you have those that are truly cryptogenic. We don't really know why that they have steatotic liver disease. It's very occult. But then you also have alcohol-associated liver disease, which is still the number one reason why people need liver transplantation in the United States in men. So significant alcohol can contribute to, steatotic appearance and fibrosis related to alcohol. But then, one of the nomenclature changes that I think is a benefit is it really characterizes this in-between group between metabolic dysfunction versus alcohol-related liver disease, especially in this population where they also have true metabolic features. But, it's really important to know that some of those patients can have, due to the increased alcohol intake, are they mast cell predominant or are they, alcohol liver disease related predominant? And it really, breaks down based on the weekly intake. And we all know, unfortunately, that females cannot drink as much as men. And so you really need to do an extensive alcohol history and intake to really get a sense and exclude concomitant alcohol use that can be a potential driver of their steatotic liver disease, even though they have predominant, or maybe more than one cardiometabolic factors that, is pointing you towards more of a diagnosis of metabolic dysfunction. So, females unfortunately can't have more than 20 grams per day versus 30 in men. And then there's a range where you can see where it's alcohol predominant when you suspect when females drink more than 50 grams a day and men drink more than 60. And then also on the above that, you'll see the weekly alcohol intake. So again, the first number is representative females, and then the second number, 210, is males. And then, again, you have that range. And then you have the alcohol predominant of 350 grams per week for females and 420 grams for men. So, what do we say is a drink? And I think, it's important not only to ask, our patients how much they drink, but what they drink, because the alcohol content varies between different types of drinks. So the standard regular beer, which is 12-ounce can, like Miller Lite or Corona Light, or, they have an alcohol content of about 5 grams per drink. Now, this isn't including like a lot of these new IPAs and microbreweries that actually tend to have a little bit more alcohol intake. But a standard beer, 12 ounces, is about 5 grams. But, a lot of these, specialized beers can have more alcohol intake. Now, let's go to wine. I don't know a lot of people that drink malt liquor, but, wine is, a favorite drink of many people. And so a typical serving size is about 5 fluid ounces. And that is equivalent to about 12 grams of alcohol. So if you remember our patient, she noted that she drinks 2 glasses of wine per day. Now, it's funny, and sometimes I joke around with my patients, but, I always say, how big is your glass? Because, I don't know if people are, pouring out exactly 5 ounces. When you go to restaurants, sometimes you can get 6 to 8 to 9 ounces. And so again, 5 ounces is standard 12 grams per day. And then when you, and of course, if you drink other specialized things like sherry, again, the alcohol content increases. And also, the standardized drink in those drinks is about 3 to 4 ounces versus the 5 ounces of, standard table wine. And then it also goes up as you drink, brandy or cognac, per shot, which is about 1.5 ounces. And then when you go into like 80 proof or, a lot of other drinks, drinks like, bourbon and others, they tend to be 100, 110 proof, and one standard, drink, which is equivalent to 1.5, and that's just a single, but a double, you're going to have to double the grams. 1.5 fluid ounces per shot is equal to 40 grams of alcohol. So way more than what females, can drink. But remember, in our case, she, denoted that she drank 2 glasses of wine per day. So, alcohol versus non-alcohol metabolic features, the risk factors, then you get impaired lipid, handling, because the liver is responsible for intrahepatic lipid metabolism, and it causes, any of these metabolic features, and including alcohol, also increases oxidative stress and increases the rate of apoptosis, which is cellular program death. And NAFLD, or non-alcoholic, or metabolic dysfunction and other alcohol-related disease factors disrupt the microbiome in the gut, which then subsequently increases in the inflammatory response, including chemokine upregulation, neutrophil-mediated immunity, and macrophage activation that then activates stellate cells that like to be nascent, that like to not be awake, but then that, due to the inflammatory response, then activates hepatic stellites that then it increases, the acceleration of fibrosis and disease progression. So again, it's very difficult to distinguish, MASLD versus from alcohol-related liver disease. They also even have similar appearances on biopsy. So this is where the social history will help really determine, is this someone truly MASLD? Is it someone truly alcohol? Or are there in the in-between where there are this MetALD that could be MASLD predominant or alcohol predominant based on, your extensive social history of their alcohol intake. So as we can see, there is a spectrum of steatotic liver disease, which include MASLD, MetALD, and advanced, and alcohol-related liver disease. And, we know that concomitant alcohol use, if you do have MASLD, increases the risk of increasing their risk for fibrosis and advanced fibrosis to progression to cirrhosis. And as you can see on the upper part of the slide is that as the kPa increases, which is a biomarker for hepatic stiffness and which is a surrogate for hepatic fibrosis, that as you get further and further close to F3, F4, you have a cumulative risk of developing decompensated cirrhosis, which can increase from 5 to 15% over to 15 to 50% 5-year risk as you develop, more advanced fibrosis going to cirrhosis. So what are the biomarkers, that we use in clinical practice that can help us with, determining how much alcohol intake our patients, truly, imbibe every day? And I think that, and we all know that our patients tend to underestimate their drinking, right? So, and, when we have 20 minutes with these patients, right? It's very difficult to address their health problems, but do an extensive history. So one of the best practices that we do in our clinic, when we do a FibroScan, our nurse actually performs the audit 10. So that way that we can get a good, accurate assessment of, how much alcohol is contributing to their liver disease. So, because again, metabolic function and metabolic dysfunction risk factors, but also especially type 2 diabetes and obesity, and poor diet and sedentary lifestyle, although that they're, the most common risk factors for MASLD, but, we want to make sure that we understand how much alcohol is really contributing to, their overall liver health. So we can, obviously ask them, by detailed inventory, but there are also some biomarkers that we use either in the urine or the blood that can actually screen for alcohol consumption. And so, but we do know in studies that people that have metabolic dysfunction tend to also have concomitant moderate to excessive alcohol intake that's contributing to their overall liver health. And we do have, urine and ETG levels, and, we can do audit C, audit 10. But again, that can also underestimate, I don't think that patients intentionally lie. I just think that they tend to not really understand what a standard drink, and they just don't know as much as we do as far as you know what they're truly intaking, right? So, but luckily we have markers that can also tell us in the urine or in the blood, to better estimate how much they're drinking, and we use the PEth test a lot in clinical practice. So, when you have people that have, the common risk factors for metabolic dysfunction, right? And you have, these criteria of BMI, fasting glucose, blood pressure, triglycerides, these are all, criteria of the metabolic syndrome. And then if they have isolated hypertension or hypertriglyceridemia, you want to make sure that they don't have obvious, increased alcohol intake, and to truly define them as metabolic dysfunction associated steatotic liver disease. Because remember, it's almost a diagnosis of exclusion. But, you should consider those, especially with hypertension and hypertriglyceridemia, because and consider PEth testing to really get an accurate assessment of how much they're really drinking. Because on the other spectrum, on the other side, is that you can have steatotic liver disease that, may be purely driven by alcohol. But let's face it, a lot of our patients that are over 50 in the 60s, they tend to have, the cardiometabolic risk factors. But, it's really important that we assess their alcohol to see, is it really metabolic dysfunction that's contributing to their liver disease, or is it purely alcohol, or is it both? We use PEth tests too a lot, especially in the transplant world. So the PEth test, so you can see that a PEth score of less than 10 to 20 really really reflects over the past 3 to 4 weeks, either that they are not drinking or that, they have very low alcohol consumption. A PEth score from 20 to 200, reflects moderate to heavy alcohol intake. And a PEth greater than 200 is pretty much reflective of excessive alcohol consumption. And, our patient here, her PEth score was 120. I mean, she didn't hide that she was drinking, but, 2 glasses of wine per day per every week, will add up, which does reflect, a pretty moderate to heavy alcohol consumption. So with the PEth, it can be detectable for 3 to 12 days, especially after even one single drink, and it has a mean half-life of 3 days. And there was no significant variability by sex or by BMI. And so, but, we know that PEth tests can also can detect alcohol up to almost 3 to 4 weeks. So it's a longer test for, alcohol consumption, very similar to the hemoglobin A1C for diabetes. And there was a study here that, patients that were screened for a particular study, and they were trying to risk stratify, and they found out that, there was a significant amount of folks that, were analyzed and they were suspected to have metabolic, MetALD, because it wasn't just purely metabolic dysfunction that was contributing to, you know, contributing to their liver health. And as you can see in this study, alcohol use in individuals with excessive weight, that 97 of the ones that were enrolled of 333, 97 of them, so a third of the population was actually suspected to have MetALD than just classically metabolic dysfunction alone. So again, which then it revealed that almost 16% of these people were at risk for metabolic, MetALD instead of just MASLD. So even in this case where she had, she was overweight with a BMI 29, very close to the BMI 30 for obesity, but, she definitely has metabolic risk factors, cardiometabolic risk factors, such as hypertension, hyperlipidemia, and PCOS. Okay. So, and also her physical exam, was reassuring that she doesn't have overt cirrhosis. So here, how does alcohol affect hypertension? And so interestingly, alcohol has this biphasic effect on blood pressure. It decreases blood pressure up to 12 hours of consumption, but then it can increase blood pressure after 13 hours after consumption. And it was interesting in this study, the effect of alcohol on triglycerides. And you can see here on the left that, they actually studied blood samples of those that were given 2 standard drinks versus water. And as you can see that the mean plasma triglycerides actually increase with alcohol versus those that drank water. And that you can see that over 10 hours, it really peaked, and how it can increase the mean concentration after having those 2 drinks. And these are standard drinks. These are, again, it's important to know what a standard drink means. So let's go back. I think there was a little mistypo on the laboratory because the AST was a little higher than the ALT. But, this is a great case because she really reflects patients that have multiple risk factors or cardiometabolic risk factors for MASLD, but she drinks 2 glasses of wine per day, right? So again, that's 24 grams. And if you multiply it by 7, assuming that she drinks just that even every day on the weekends, you're talking about, let me do my math here, 24 times 7, you're talking about, 130 grams of alcohol per week. Even though she has, in addition, cardiometabolic risk factors. And so alcohol can certainly play a role in increasing her hepatic risk of fibrosis. Right. So, which, was evident here, in her transit elastography with a KP of 11.4, which is very concerning. And I think it's a good opportunity to not only tell her about her cardiometabolic risk, but also the additive risk of her alcohol consumption. So we diagnosed her with MASLD-predominant MetALD because she wasn't 240 grams or the excessive, but she still has metabolic features, but she does have MetALD, but it's still more predominant because she only drank 2 glasses, of wine per day. So what are the current treatment options? So obviously, because she is overweight, you want to emphasize still the cornerstone of any type of metabolic liver health or steatotic liver health, which is to lose weight. There's a lot of data on the Mediterranean diet, and also we want to support her with overall liver health and reducing her cardiovascular risk because that's still the number 1 killer in patients with MASLD. Okay, and so you want to encourage exercise, weight loss, and is she a candidate for resmetirom? And because there's really no data on the MetALD population, I think that if she could stop her alcohol cessation and reassess her, and she's still F2 or F3, then you can consider, candidacy, because then right now, then she's truly MetALD. But if she actually stops alcohol and her, again, she's predominant, MASLD, I think that, with reassessment, and obviously monitoring her PEth test, you can consider her, for resmetirom if she is still more than F1. But you need to strongly counsel her about stopping alcohol, because I always talk about alcohol being an accelerant. So it's like, I always tell my patients, it's like throwing, gasoline on fire. And then the question, begs is, does she need screening for HCC? Now, even though that in most cases with people that are highest at risk, over 95% of developed the risk of hepatocellular carcinoma is really predominantly those with cirrhosis. But we also know in patients with metabolic dysfunction that they have higher rates, especially not only in primary liver cancer, but they also have an increased risk of developing extrahepatic malignancies. So would I screen her for HCC knowing what our KPA is? I would say yes, because we are seeing more and more that patients with metabolic dysfunction are being diagnosed with HCC. That's also the predominant reason for those, the predominant etiology for those that are listed for HCC on the liver transplant list. It doesn't meet the threshold of, saying that there's going to be universal, screening for those with HCC with advanced fibrosis. But in my practice, I would advocate for screening just because of the alarming rates of primary liver malignancy and the absence of cirrhosis, very similar to the Hep B population for those with metabolic dysfunction. So I think that there's more work to be done in the field, especially in defining. I think there's a lot of controversies in defining what MetALD means, especially for clinical trials, because, it should be based on objective biomarkers, to overcome underreporting of alcohol use and actually standardize the assessment of how to, grade alcohol use and to certify alcohol abstinence. So this is where you're going to see a lot of studies. Will you be using some type of objective biomarker for true alcohol intake? And we have to also ensure that drivers of liver disease are present, because we have to make sure that, those that have more than one cardiometabolic risk, or they have persistence of, these risks, especially hypertension or hyperlipidemia, even after, the cessation of alcohol. So, and you also want to make sure that, we fulfill the criteria during the last 6 to 12 months, especially for those that, are ideal candidates and those that meet the true definition, which is controversial for MetALD for clinical trials. So really, I'm going to end by the take-home messages here is that, alcohol intake beyond 140 grams and 210 grams per week for women and men respectively is the new definition for MetALD. This really requires, a good assessment, a social history assessment, and also the use of current standard biomarkers that can quantify, alcohol consumption. The clinical criteria could underestimate MetALD, but also alcohol-related liver disease. And you want to use alcohol biomarkers, including PEth or whatever you have available. But, PEth is the longest test that will reflect, the alcohol consumption for 2 to 4 weeks. We also want to ensure that drivers of liver disease are present. And even after alcohol cessation, we should reassess those with metabolic dysfunction over time and consider their adequate exposure to risk factors. And also, the criteria for clinical research should facilitate an objective MetALD diagnosis, which can allow comparisons among different socio-cultural realities. And so, again, I thank you for your time today. And if those that are interested, you can visit the GHAPP MASLD MASH Community Network for additional disease state education and more information on Rezdiffra if you are interested, and you can use the QR code to access that content. And so thank you, and I'll wrap up. And does anyone have any questions?